All right, diving right in. Today we're taking a deep dive into a fascinating and often misunderstood condition called cataplexy.
Mhm.
We've got your revision notes right here, and our mission really is to unpack them section by section.
Yeah,
We want to pull out the really high-yield nuggets for you, give you a clear picture, and maybe help you see the connections that make this information stick.
exactly. We'll break down, what it is, why it happens, who might be at risk,
Uh-huh.
how it's diagnosed, managed, and what the long-term picture looks like, all using just the details from your notes to give you that focused understanding.
Get ready to understand how something as seemingly simple as laughing can, for some people, literally lead to a sudden loss of muscle control. It's genuinely surprising.
Yeah, it really is. And this deep dive is designed to cut through some of the complexity you sometimes find in study materials and really just highlight the essential points for revision and understanding.
Okay, so let's start right at the beginning then. Based on these notes, what is cataplexy at its very core?
Well, at its core, your notes define it as a sudden and temporary loss of muscle tone and control.
Sudden and temporary loss of muscle control. And the trigger. The notes seem pretty specific about what brings it on.
They do, yeah. It's triggered by strong emotions, things like laughter, excitement, or even anger or surprise.
Right. Now here's where it gets really interesting right off the bat. Your notes immediately link it to another condition.
Yes, that's crucial. It's listed as a hallmark symptom of narcolepsy, specifically type 1 narcolepsy, which is a neurological disorder affecting sleep regulation.
So it's not usually just a standalone thing, but part of this larger neurological picture.
Yeah.
Okay. What does an actual episode look like for someone who's experiencing it?
The notes describe the symptoms as varying pretty widely. It can be anything from, say, a mild muscle weakness, maybe just a slight drooping in the face,
Mm-hmm.
perhaps slurred speech, all the way through to a complete collapse.
Wow. Okay. So it's a sudden emotion-triggered muscle weakness or paralysis, often tied to narcolepsy type 1.
Yeah.
That gives us our starting point.
Got it. So, moving from the what to the why, how does this actually happen? Your notes connect cataplexy and narcolepsy type 1 to something quite specific going on in the brain.
What's fascinating here, I think, is the link the notes make to an autoimmune process.
Autoimmune.
Oh, yeah. The notes state this process destroys neurons that produce a really crucial chemical called hypocretin, which is also known as orexin.
Hypocretin.
Yeah.
Right. That sounds important. What role does it usually play?
According to the notes, hypocretin is key for regulating our sleep-wake cycles. So, when these neurons are attacked and destroyed, that fundamental regulation gets disrupted.
And is that loss directly responsible for the symptoms we just talked about? Both the sort of excessive sleepiness of narcolepsy and the muscle loss of cataplexy.
That's exactly what the notes explain. They state that this hypocretin deficiency leads to the sleep-wake dysregulation.
Which then manifests as both the excessive daytime sleepiness you see in narcolepsy and these emotion-triggered cataplexy episodes. It's like a single deficiency causing two seemingly different problems.
Interesting. Beyond that core autoimmune mechanism, do the notes mention other factors that might contribute to developing narcolepsy with cataplexy?
Yes, they do. Genetic and environmental factors are thought to contribute to the overall development of the condition. And specifically, a genetic predisposition is listed as a risk factor. So yeah, building on that idea of genetic predisposition, your notes list out some specific risk factors for developing this condition.
Let's make those clear for you listening. What are the key risk factors highlighted in the notes?
Okay, so the notes mention having a family history of narcolepsy or cataplexy.
Makes sense.
That genetic predisposition we just talked about, like certain HLA alleles, though the notes keep it general here initially.
Okay.
Then certain triggers like strong emotions, obviously, or even having other autoimmune disorders. And finally, broader environmental factors that can influence narcolepsy development.
Okay, so it's a mix then. Genetic vulnerability, family history, and maybe external or coexisting factors like other autoimmune issues and the environment. This sudden loss of muscle tone triggered by emotion. I mean, it sounds like it could easily be mistaken for other conditions, right? What does the differential diagnosis section in your notes guide us through?
That's a really important point for diagnosis, yeah. The notes list several conditions that definitely need to be considered and distinguished from cataplexy.
So like ruling out fainting is one.
Yes, fainting or syncope
Yes.
is listed because, both involve a sudden loss of posture.
Right. What about things like seizures? Could it look like that?
Epilepsy and other seizure disorders are definitely on the list. The sudden, sometimes quite dramatic physical changes could certainly be confused.
And stroke-like events. mini strokes.
A transient ischemic attack, a TIA, is also included as something to differentiate.
Yeah, okay. What about other sleep-related issues, since it's linked to narcolepsy?
Good point. The notes mention distinguishing it from other sleep disorders, particularly things like sleep paralysis and hallucinations, which can co-occur with narcolepsy but are distinct phenomena.
Uh-huh.
And they also list cataplexy-like episodes and other conditions, sort of acknowledging that similar symptoms can sometimes appear outside of classic narcolepsy type 1.
So it sounds like if you see sudden muscle weakness, it's really crucial to systematically rule out syncope, seizures, TIAs, other sleep issues, and these other conditions that might mimic it.
Exactly. A careful differential is key.
How common is cataplexy? Or, I guess, narcolepsy with cataplexy? What do your notes say about the epidemiology, specifically looking at the UK?
Well, the notes classify it as a relatively rare condition overall.
Okay. Are there actual numbers provided for prevalence?
Yes, for narcolepsy with cataplexy, the estimated prevalence in the general population in the UK is given as being somewhere between 0.02% and 0.18%.
0.02 to 0.18%. So yeah, quite low. And is there separate data for cataplexy alone, maybe without the full narcolepsy diagnosis?
The notes state that there's actually limited specific data available for cataplexy presenting in isolation in the UK. So the numbers we really have are primarily linked to narcolepsy type 1.
Got it. Okay, let's dive back into what an actual episode feels and looks like. Your notes go into a bit more detail on a clinical presentation and features. What are the key things to remember here?
Well, the most striking feature, and it's reiterated here, is that sudden, emotion-triggered loss of muscle tone.
Right. And unlike fainting, or maybe a seizure, your notes make a really crucial point about awareness during the attack.
Absolutely. This is a key distinguishing feature. Awareness and consciousness are preserved during the episodes.
So the person knows what's happening.
Yes, exactly. They're aware of what's going on, even if they can't move or respond.
And the severity really varies, doesn't it?
It does significantly. The notes describe the spectrum ranging from very mild events, like just the slight slackening of facial muscles or the jaw dropping, which might look like drooping facial muscles, maybe leading to slurred speech or even blurred or double vision, all the way up to a complete sudden collapse of the body.
Wow. We mentioned triggers earlier, but are there more details on the specific emotions here?
The notes just reiterate the common emotional triggers. Laughter is frequently mentioned, that's the classic one, but also excitement, anger, surprise, or even embarrassment.
Right. And how often do these episodes happen? Is it predictable?
Well, the notes state that the frequency varies significantly from person to person. It can be anything from very frequent episodes, maybe multiple times a day, to quite rare occurrences.
Okay. The notes also mention it often comes sort of hand in hand with other narcolepsy symptoms.
Correct. It often co-occurs with that excessive daytime sleepiness, sleep paralysis, or those hypnagogic or hypnopompic hallucinations, the ones just as you're falling asleep or waking up. They're all part of that broader narcolepsy picture.
And the muscle weakness itself, does it always affect both sides of the body equally?
Usually, yes. The notes say it's typically bilateral, meaning it affects both sides. But they do make the point that it can occasionally be unilateral, just affecting one side.
That's interesting. Your notes also give some specific pointers about taking a history, suggesting what questions are particularly important when you suspect cataplexy.
Yes, they really emphasize getting a detailed history. It's crucial.
Like what specifically?
Asking about typical sleep patterns, assessing for unusual or inappropriate sleepiness, falling asleep in strange situations, also exploring medical conditions, employment impact, any substance use or medications, family history, of course, and getting a very specific description of the symptoms themselves. And they give a really crucial tip, specifically asking about partial weakness, things like mild facial or jaw weakness, because patients might not actually report these milder forms spontaneously. They might not even realize it's part of the same thing.
That's a good point. You'd have to ask directly.
So once you have that clinical suspicion based on the history, how do doctors actually investigate suspected cataplexy according to your notes?
The notes seem to point towards a thorough clinical approach, first and foremost.
That's right. A detailed medical history and a clinical evaluation are the essential starting points. You can't skip that.
And then you move to the objective tests, particularly the sleep studies.
Exactly. The notes list sleep studies, including polysomnography, that's the overnight sleep study. It monitors sleep patterns and helps identify other potential sleep disorders, too.
Right.
And the multiple sleep latency test, the MSLT, is also mentioned. This test measures how quickly someone falls asleep during the day in controlled naps, and it helps quantify that daytime sleepiness.
Your notes also mention measuring something specific in the spinal fluid. What's that about?
Ah, yes, this is a fascinating detail. The notes include the measurement of hypocretin levels in the cerebrospinal fluid, the CSF.
Because low hypocretin is the cause. Right.
Exactly. As we discussed, low hypocretin is central to the pathophysiology in type 1. The notes say measuring CSF hypocretin can help confirm narcolepsy with cataplexy, but interestingly, they note it is not routinely done.
Interesting that it's not routine, given how central hypocretin seems to be.
Hmm.
Are there other investigations listed?
Yes. The note suggests using the Epworth Sleepiness Scale. That's a standard questionnaire just to quantify the level of daytime sleepiness subjectively.
Okay.
They also include performing an EEG, an electroencephalogram, and considering a brain MRI. These are primarily to help rule out other neurological causes for the symptoms, like a seizure disorder or maybe a tumor or lesion pressing on brain areas.
Makes sense. And what about specific biological markers mentioned in the notes? Biomarkers.
They do point out that biomarkers like low CSF hypocretin levels and also the presence of a specific genetic marker, the HLA-DQB10602 allele, these are noted as being sensitive in patients who definitely have cataplexy. But they add a bit of nuance. Their certainty or predictive value is less certain in patients who have narcolepsy without cataplexy.
Okay, so it's a range of tests,
I
but
don't-
the clinical picture and the sleep studies seem pretty central, with CSF testing being maybe confirmatory but not routine, according to your notes anyway.
That seems to be the picture painted by the notes, yes.
So once cataplexy is diagnosed, how is it typically managed according to the notes? What are the approaches?
Your notes cover several key approaches to management. First off, education and counseling are highlighted, just making sure the patient really understands the condition, its triggers, and how to manage it day to day.
Right, that sounds fundamental. Are medications a big part of it?
Yes, medications are mentioned for symptom control. The notes list using drugs like SSRIs, that's a type of antidepressant, TCAs, another type of antidepressant, and also sodium oxybate.
Okay. What about things patients can do themselves? Lifestyle changes.
Definitely. The notes suggest lifestyle adjustments are important, particularly focusing on good sleep hygiene, trying to get regular sleep, and also trying to identify and perhaps avoid specific emotional triggers where possible, though that can be hard.
Yeah, I imagine. And supportive therapies.
Supportive therapies are included too, aimed at helping with daily function and maintaining emotional well-being, given the impact the condition can have on life.
And is it a condition that requires ongoing care, check-ins?
Yes. The notes recommend regular follow-up appointments. That's for monitoring treatment effectiveness and making adjustments as needed over time.
Your notes also have a specific section on managing the cataplexy itself, not just the narcolepsy overall.
Right. They emphasize providing support and information specifically around the cataplexy symptoms. And crucially, they state that symptom control is the primary goal because there is no cure for cataplexy listed in these notes.
No cure, but symptom control. Are specific drugs listed as first-line treatments for the cataplexy attacks themselves?
Yes, the notes state that sodium oxybate is generally considered the first-line treatment option for cataplexy.
Okay.
They also mention that those antidepressants, the TCAs and SSRIs, can also be effective in reducing the frequency or severity of the episodes. Selegiline is listed as another potential option, but the notes mention it has limitations.
Right. And looking ahead, are there mentions of future potential treatments being explored?
The notes briefly touch on future possibilities, listing areas of exploration like immunological therapies, perhaps targeting that autoimmune process.
Interesting.
Investigating histamine H3 receptor agonists, considering hypocretin-based therapies, things like hypocretin agonists, maybe even cell transplantation or gene therapy, and even exploring nicotine as a potential therapeutic avenue. So lots of research areas.
This is ongoing work.
Definitely. Finally, let's look at the long-term outlook and potential issues. What do your notes say about the prognosis and possible complications of cataplexy?
The notes characterize cataplexy pretty clearly as a chronic condition.
They do, emphasizing that it has a lifelong impact on daily life for individuals. It doesn't just go away.
But is it life-threatening in itself?
No, the notes explicitly state that cataplexy itself is not a life-threatening condition.
That's really important to know. but it clearly affects quality of life quite significantly.
Absolutely. The notes mention it significantly affects social interactions and overall well-being, which makes sense, doesn't it, given the unpredictable nature of the attacks triggered by common emotions?
Yeah. The good news, though, is that management seems to make a real difference.
Yes, that's the positive outlook presented. The notes state that with appropriate management, individuals with cataplexy can indeed lead fulfilling lives.
That's good to hear. And what about complications? Are there specific issues linked directly to the cataplexy itself?
Well, the notes link the potential complications primarily to the other associated narcolepsy symptoms,
Ah, okay.
like the excessive sleepiness and the other sleep issues. These related symptoms are noted as having an impact on both physical and mental well-being.
So it sounds like addressing those broader narcolepsy symptoms, the sleepiness, the sleep disruption is key to improving the overall picture and prognosis for someone with cataplexy.
That's essentially the conclusion the notes draw, yes, stating that addressing these associated complications is crucial for improving the prognosis and the individual's overall quality of life.
So we've really unpacked cataplexy from your notes there. We've gone from its, well, quite surprising definition rooted in emotion and muscle control,
Mm-hmm.
through the complex autoimmune cause linked to hypocretin, how it's diagnosed and managed, and understanding its chronic nature, but importantly, the positive management outlook. We've seen how varied its presentation can be, from maybe just mild facial weakness to full collapse, while consciousness remains intact, which is a truly unique feature.
Yeah, we've highlighted that while there's no listed cure in these notes, effective management strategies do exist, from lifestyle adjustments and education right through to specific medications, offering real hope for individuals to live full lives despite the condition.
Thinking about how intrinsically tied cataplexy is to emotion, and how emotions are just an unavoidable constant part of everyday life. Here's a thought maybe to leave you with. Beyond the medical treatments and the strategies for maybe avoiding specific triggers, what might be the single biggest non-medical challenge for someone living with this condition in just navigating their relationships and their social world day to day? Something to ponder.
That's a really interesting question.
So that wraps up our deep dive into cataplexy, based directly on your revision notes. We really hope breaking it down like this, point by point, connected the dots and highlighting the key features has given you a clearer, maybe more memorable understanding for your studies.
Absolutely. Remember, actively engaging with and synthesizing the information is what really helps it stick.
And if you are gearing up for the MSRA or just want more resources on related topics, be sure to check out pastmsra.com.
And don't forget about the free resources that are available at freemsra.com as well.
Thanks for joining us on this deep dive.